You are a specialist in urologic oncology and were recently the president of the American Urological Association, and you are also a prostate cancer patient yourself. Can you tell us a little bit about that?
Well, as a urologic oncologist, I've specialized in prostate cancer treatment for the past 20 years, and 10 years ago, I like to say I went from being treated to the target, namely a elevated PSA led to a biopsy and the diagnosis of prostate cancer. And the emotional reaction was quite profound and unsuspected. I often am asked by patients, what would you do, doc, in this situation? And I realized that the hypothetical feeling of what you would do doesn't match the reality testing of hearing the news and then trying to assimilate the results, even though I certainly had plenty of information. And then began my, we'll say, path or participation in the prostate cancer process, not only from a physician but a personal standpoint.
What do you see as the most critical things that a man should know today to ask their doctor about as they begin the process of the possibility of being diagnosed with prostate cancer?
There are issues with regard to age, health, racial background, etc., that certainly place some men at higher risk than others. But in general, when a patient approaches a urologist or a family practitioner with that question, I think it's a very individualized assessment of his risks, his comorbidities, which is to say what other problems he may have, and the degree to which he wishes to pursue a diagnostic test and maneuver for determining if disease is present. And it certainly differs from one patient to the other.
Do you personally recommend that men get a baseline PSA value in their mid-30s or 40s?
There's information from a large Swedish study that would say that men in their 40s can be assessed as to their risk for prostate cancer based on we'll call it a baseline PSA done at that age, predicting the likelihood of prostate cancer 20 years later. And so I think that it is a reasonable effort to dichotomize patients who are at very low risk if their baseline PSA at age 40 is very low, and what's very low, 0.2, 0.3. And those who should be more suspicious of a problem if their PSA is above the median for that age group, which is 0.6 or 0.7. So again, it's an effort to raise the alert, we'll say, flag on one group and to suppress the anxiety in another group, but that is not a universally held thought.
What are the things you tell your own friends and neighbors today when they ask for your advice about the best treatments for early-stage prostate cancer?
First thing I tell them is they have time on their side, and that by all means not make any hasty decision. And by that I say take months, literally months, to gather the information, dwell on it, sleep on it, see what kind of emotional response they have. Some folks feel that they really need to separate themselves by a surgical procedure from the cancer, the malignant organ, and others feel that they would be very satisfied with a treatment that does not involve surgery, recognizing that both of those approaches are quite reasonable. And then emphasize for some individuals, if they have the mindset that permits what we now call active surveillance, that is a very appropriate direction. But the main thing is no hasty judgments, take time, and time is on your side with regard to making a decision.
Can you talk to us about what you think the Provenga data means for the treatment of prostate cancer in the future?
Well, we have in this trial proof of principle that what was hoped would be an effective cancer therapy, namely immunotherapy, really has materialized into through a very appropriate randomized controlled trial to show a benefit in survival with minimal toxicity, with therapy that can be delivered over a very short time interval of 1 month. So My feeling is that it opens the fourth modality of therapy in addition to surgery, radiation, and chemotherapy for prostate cancer, and that it holds promise for improving survival with minimal side effects.